Speakers. The first one I would like to introduce is Dr. Rao Khalid. Dr. Rao Khalid is a laparoscopic surgeon with an experience of more than 700 laparoscopic colorectal dissections with excellent results audited locally and nationally in England. At present, Dr. Mahmood is working as a substantive consultant at Barnsley Hospital. Dr. Rao Khalid Mahmood.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Thanks for inviting me on such on a prestigious platform to talk about. I'm sorry, I got a bit sore throat. So if you put the slides on, please. So as you heard in the intro that I'm working substantively at Barnsley Hospital, but currently I'm on employment break here in Pakistan for a year, so it is nearly that's my 6th month in this country, especially in this city. So what I'm going to talk about is primarily what I have noticed. So this is a personal repertoire. It is a personal analysis of the challenges which I faced in this country in the last 5-6 months. So they are not validated claims. They are just, I've discussed these kind of analysis with my friends, with the surgical fraternity. So you can call them as anecdotal, evidence-based. So, and I got a few solutions, which I think the whole idea is to talk about, at least to start the debate, to initiate the questioning. So that's me, and let's start with the first slide, please. Next slide, please. मेरे पास है point. So the challenges which I faced, कौन सा दबाना? Okay. So the challenges which I've analyzed or faced, the challenges with the awareness, with acceptance, with apathy, with absenteeism, with this is not the challenge, this is what we got in this country, abundance. But we need to ascertain where we are going and how we need to accomplish. So the idea is, we have heard about in this session what exactly we are doing in this country. We have heard about this audit as well, and you have seen that in the previous sessions of COLOCON, the advanced laparoscopic surgery, but this is my personal repertoire. So COLOCON, as you know, you heard about COLOCON very well, that this is a great effort of Professor Amjad Siraj Memon and his colleagues, who made it possible with the patron-in-chief, Professor Saeed Qureshi, Professor Naved and others, and my dear friend Khurshid Sammo. So, and you heard about it, so I'm not going to talk about COLOCON further on. So what I have noticed working in this country, I found the issues of awareness about laparoscopic colorectal surgery, whether it is for the cancers or for the benign diseases. Public is not very much aware of this new technique. We have talked about that probably in the 5-6 days of COLOCON, whatever the number of days we are here, and tomorrow we'll be here as well. We talked about screening, and probably the speakers after me will talk about that as well. But I found that awareness about the screening is still lacking, and the importance of screening is not very well understood by the nation or by the medical fraternity. Then what I've noticed working in this country, that the trainees are not very well versed. They are lacking the true understanding, even the senior trainees, what the laparoscopic colorectal surgery stands for and how we do it, whether it is for benign or it is for cancers. Forgive me, it may be a tall claim, but that's what I have noticed. You can debate about it. I'm going to say, with due respect, I think the senior surgical fraternity may be more supportive to create the better understanding among the public and among the junior surgical fraternity who's going to take over from us in near future. So now, what I call acceptance and apathy, in my view, you've seen Professor Chima and Professor Taz Qureshi and others operating on these wonderful machines, Da Vinci, which is even the SI, not even XI. And we know that they are the stars of their time. But the point is, the laparoscopic surgery needs acceptance rather than robotic surgery. Robotic surgery is becoming a norm in England as we speak in this part of the world. However, what I've noticed that if the laparoscopic surgery is the norm in the other parts of the world and robotic is becoming the new standards, is this norm is a norm in this country or not? We need to ask this question from ourselves. And what I call apathy, if the new techniques are basically being norm in the other parts of the world, and if someone can't do it, we should not be probably declaring it's not working. That creates apathy to the new technique. It may be a tall claim, it may offend someone, but that's what I've noticed, forgive me. It may be politically incorrect slide. What I call absenteeism. So the public, as I said, is lacking education, but we need to ask this question very honestly to ourselves. Are we educating our public about this new technique, whether it's laparoscopic colorectal or it is robotic surgery or any other new techniques? And the other claim which I heard that the cost of laparoscopic surgery is very high. I think we need to talk about this cost. We need to talk whether we are calculating the cost of laparoscopic surgery only during the indexed admission when the patient is operated, as this country is mainly run by the private sector rather than the state sector. Although, as we listen that we are doing the state-owned hospital surgeries in DOTS and other hospitals. So the cost of laparoscopic surgery is not for the indexed admission only, it is in the long run as well, what the patient is having with the long cut and what's the quality of life and the patient's life afterwards and their cost which they are going to bear with the open surgery. We do have MDT culture in this city, which I'm specifically talking, but we need to ask this question very seriously with us, is that MDT culture is flourishing and taking roots, and are we taking the MDT decisions on board and operating our patients according with the MDT advice? These are my thoughts. I'm not saying that this is not happening, but this is what I think we need to ponder around a bit more. We heard about secondary hospitals, but we need to think about these tertiary referral centers. Are the concept of tertiary referral centers is taking roots on or not? Because it's very important. You'll see in my next slide what is the concept of tertiary referral center and why I'm talking about it. What this country is blessed with, this country is blessed with huge human resources, massive, massive amount of doctors, huge amount of doctors are graduating each year, going into their FCPS training. After 4 years, they are coming out. Massive amount of capital. We talk about that the patients are poor. Yes, we know that. But even then, on the other side of the river, there is, other side of the bridge, there is huge capital. This is maybe distribution may be not correct. Patients. I've heard when I was coming to Pakistan that the colorectal patients, colorectal cancers are not that much as in England. But honestly, I've seen huge number of colorectal cancers in this country, and as we've seen the slide in the audit as well, the numbers are increasing. Infrastructure is huge here. Every hospital claims that they are doing laparoscopic colorectal surgery and advanced colorectal surgeries. Policies and controlling bodies, endless. But the thing is, as Walter Disney said, the change, what I'm going to talk about in the next few slides, only happens when we stop talking and doing things. If these are the right claims, if these are the right questions, when we ponder around then, I think we need to bring some solutions out as well. We need to accomplish few things. What we need to talk about. I'm not going to specifically talk about the training program in this country, but because I see this is my personal analysis, as I said before, and these ideas I brought out after my own analysis in general, what's happening in the country and how we can fix probably. So the first thing is the new breed of surgeons who are coming and will be the vanguard of the surgery and taking flag over from us. Let's look at the training scheme in the other parts of the world. The length of postgraduate training scheme in United Kingdom and Ireland is more or less stands for nearly 10 years. This is before the specialist training. You got a core training, the internship, core training, and the specialist training. And every country is probably roughly 6 years, United States and other years. Only Colombia stands for 4 years. The minimum numbers of surgical procedures you need to produce your logbook as a trainee. United Kingdom and Ireland stands for nearly more than 1,500 cases, which should be validated. The logbook should be validated by trainers. And in the last 2 years of training, the DOPs are done. They are validated cases by the 3 different consultants that you can do a APR, and that has been DOPed, and that's been seen. So the other, if you want to go with the lower number, South Korea only needs 64 cases. I don't know what these 64 cases are, appendix or something, God knows, but that's what the paper says. So this slide is about volume. That is the slide about my previous slide, which I said, the tertiary hospitals. This is about volumes, and it speaks volume in itself, to be very honest. I put the gastrectomy, which more or less every general surgeon is doing it here. Look at the slide, the low surgeon volume, 895 surgeons operating on 2,336 patients. One patient is getting nearly less than 3 patients per surgeon, and the mortality is 12.2%. And then it goes to the high surgeon volume. This is the concept of tertiary hospitals, which I was talking about. Every hospital in this city is doing more or less everything. 91 surgeons have operated on 2,281 patients. The mortality is 4.3%. So this slide speaks volumes. So you can see that what's the difference is. There is a score called Customs score, cumulative sums score. And this is, I've took only the mortality, which is obviously the end result for the surgeon and for the patients. I could have spoken about the anastomotic leak, about the quality of life, about post-op complications. I didn't pick that. I picked the last thing, which is mortality. Obviously, it is not only for me and for surgeons and for you as well as a surgeon, which matters. The other chart on the slide is for all of us. We talk about the numbers, we talk about the learning curve, we talk about how we can make ourselves better. Again, the volume. See, this is the linear representation. The number of cases you're going to do, you're going to get better. The English proverb is, more you're going to do, more you're going to get better. Very simple principle. So if you see the quality on the one side, on the longitudinal axis, if the number of the patients are less, obviously your quality will be poor. As soon as the number of the patients increases, your quality will get better. The quality here comes with each and everything. So, and there in the middle point, which is a surrogate point, which is a threshold, you can calculate by, the local surgeons can calculate by themselves. In England, it is 20 patients, the 20 cancers a surgeon must need to do, keep his skills annually. So that is more or less the same numbers as I put in the high surgeon volumes, 25 cases per surgeon. So you can see this is the most important way of going for the tertiary hospitals and getting the best results. What I've noticed about these tertiary hospitals and bringing this new breed of surgeons who can change the country's map, the paradigm shift only can happen if we need to have a leapfrog. We need to bring the young, energetic, trained surgeons, in my opinion, from overseas, who needs to take over the reins and train the local surgeons here. The local training system is good, probably, but we need to have more hands-on people from abroad so that we can be at par with the international community. So the choice is yours. The laparoscopic surgery, which was holding the emblem and holding the beacon, is still holding the beacon, but believe me or not, in England, I can talk only about England, is dying, whether you like it or not. It's robots which is coming in laparoscopic colorectal surgery. So it is your choice whether you want to laparoscope, you want to be a laparoscopic country, you want to be a robotic country, or you want to be an open country. It's entirely your choice. The world is changing. We need to embrace the change. If you need to embrace the change, we need to think very differently. Thank you very much. Any questions, I'll take.
Now you have come over here, you must have faced a lot of difficulties establishing laparoscopic surgical procedures because you need a good assistant, you need a team. So just point out what are the main difficulties in which we can go and start improving on them. Because yes, our trainees are not so well trained, we don't have a structured training system, and at times you feel lost that you want to do something and your assistant is not coming with you, and so many things. So because you have just recently come back, if you point out those particular points which we can improve upon, would be good for us.
So in my opinion, as I said before, so in a structured training system, we can only produce the trained trainees. So the best thing would be, given the circumstances, I personally believe the hospitals, which are the teaching hospitals, they need to induct people who are more trained, and they need to be given this responsibility to train rather than to shine himself or herself. This should not be a personal kind of, the program. It should be a national program, and these people who are brought here, they should be brought with one point, one agenda only, that they're going to train the new generation of surgeons. And they need to have this kind of feeling that they are here to train rather than to exalt themselves. That's the way forward, in my opinion. Please.
I'm from College of Physician Surgeon, Pakistan, and this college has started this structured training program in more than 80 disciplines as a primary, first fellowship and second fellowship. And we believe in competency-based medical education, and definitely it is well-structured program. And we are also starting from January 2023 and primary second fellowship in colorectal surgery. And this is, if you will look at our curriculum, and this is very good. And definitely we are training our trainees not on the patients but on simulators. That's our good achievement.
That's very
Thank
nice. Good. I think it's a way forward to bring further super specialization as we do the subspecialty training in England in colorectal or upper GI. That's the way forward.
Any questions from the audience?
Dr. Rao, thank you for a thought-provoking presentation. I've been back in this country from England for the past 28 years now. What you allude to conceptually seems fairly intuitive, to get trained people, borrow from outside, and things will get better. But if I look at the reality of my country, this philosophy has been tried again and again and again and failed every time. Look at education, look at democracy, look at our police, look at our roads, look at the traffic. Everything has been borrowed with this concept that things will get better because they're being done better abroad. Nothing seems to work.
Very true.
I think there's a fundamental flaw, and that fundamental flaw lies in our thinking and our approach to life and such. I think the people living in this country, and by that I mean the professionals, I'm talking about this particular group of people right now, have to really have some introspection, acknowledge that we have failed massively, and the reason for our failures is ourselves, and that needs to be put right. We cannot rely on people coming from outside, bringing a magic wand and fixing our problems. It has to be done from within the system. The system has 220 plus million people in it. What you're proposing will train maybe 200 surgeons, maybe 50 surgeons, I don't know. But that's not going to affect the problems that are faced. Robotics and laparoscopic might be the way forward right now for Western countries where this is doable. But I don't see this happening in Gujranwala or some small city in Larkana or some small hospital in Larkana. This is always going to be in these larger few hospitals which will predominate, and individual surgeons will become, show-offs, declaring their skills. That's what we've become. We've become show-offs. We are flouting our skills, individuals showing off how much they can do and really not affecting the system at large. That is what needs to be addressed. Thank you.
No, I will very...
I may like to say something what Dr. Inam has said. I think this is a ground reality. We people have a lot of egos and very little skills, and we just try to pose as if we are the gods and we know everything. But there should be a change in attitude, and it is us who are going to bring the change. When I came back from England, my professor had a colonoscope and endoscope lying in his cupboard, but I was not allowed to touch it. And when I became a professor, I wrote a letter to every unit, medical and physical and surgical, that there's an endoscope over here. Whoever wants to learn, whoever wants to do, come and do it. So we have to change things, and it is us who are going to change the things. So we should work on it together, and I think the change is going to come. Thank you.
Just only one thing I want to say about Professor Inam Pal's comment. He's exactly said the same thing which I said in the previous slide. The individuals can be show-off. They can basically tell the nation that they are the star surgeons. That concept must need to die if we want to live as a nation. If we're actually a nation, I don't know whether we are just a mass hujum or a nation, I don't know. But the point is, Professor Inam Pal he's done a very nice analysis. I think he wants to bring the solution out of this nation, which should be indigenous, to be very honest. Bringing imported Wazir-e-Azams and bringing imported democracy and everything, which definitely is not going to work. But we need to look very, very seriously as a nation. Forgive me, I'm just only an individual, but look at your nation and the people who are coming behind you. When you will be here, I will be here. If we are in this country, we will be operated by these surgeons which are getting training at this point of time. So you need to think very seriously. So the nation primarily needs to sort out how it's going to sort it out itself, to be honest. The trained people from not outside are coming. There are 2 or 3 people sitting in front of you, and they have operated in the last few days, and they've shown you, demonstrated you how the things works in the other parts of the world. So this is basically raising the standard, raising the awareness. That's the way, in my opinion, in my slide I said leapfrog. Professor Saab said that it's been tried in the past. I think it may have been tried, but it should be tried with a different vision. But if you think the local solutions will work, definitely let them work. The whole idea is that the national standards needs to be raised, whether in Ladkana, Gujranwala. It should be a trickle-down effect from Karachi, from Lahore, and other parts of the country. So that's my opinion. Thank you.
Thank
So
you, sir.
I may add one thing over here. So sorry. I'm announcing here that we will be developing a training center at Civil Hospital Karachi. A new building will be made, and just for the training purpose, surgical training for not only the people of Civil Hospital, but the whole city and the whole country. I think you're going to establish, and next time you come, you'll hear that.
Thank you, sir.
So that was quite an eye-opening and enlightening talk and a discussion.